At this point in the agenda, it is my pleasure to introduce our keynote speaker, Dr. Brian Castrucci. Dr. Castrucci is the President and Chief Executive Officer of the Beaumont Foundation. Under his leadership, the foundation seeks to advance policy, build partnerships, and strengthen the public health system to create communities where people can achieve their best possible health. He has spearheaded a number of projects, including City Health, the Build Health Challenge, and a public health workforce interests and needs survey. Dr. Castrucci is an editor and contributing author of the Practical Playbook, Public Health and Primary Care Together, which helps primary care and public health groups work collaboratively to improve health across the broader population and reduce the cost to achieve it. Dr. Castrucci has published more than 70 articles in the areas of public health systems and services research, maternal and child health, health promotion, and chronic disease prevention. He earned his doctorate in public health leadership from the Gillings School of Global Public Health at the universities at North Carolina, Chapel Hill, and his master's degree in social medical sciences from Columbia University. He graduated summa cum laude from North Carolina State University with a bachelor's degree in political science. Please join me in warmly welcoming Dr. Brian Castrucci.
Thank you for the introduction. Good morning, everybody. So if you don't know Beaumont, this is how you can get in touch with us. We are definitely on the public health end of the clinical to public health spectrum. What's not in my bio is that I'm really excited to be here. Both of my parents were nurses. Both my parents were ER nurses. Dad did NICU, PICU, SICU, all the U's. And so this, I grew up with this. I was telling the organizers before this morning, my father was one of the kind of early pioneering men who was in nursing. And so I spent most of my elementary school years debating with my teacher whether I knew what my father did for a living, because she would say, "No, you mean a doctor?" I went, "No, I mean a nurse." And so I'm very proud of what they did, and I'm really happy to be here to talk to you all. So I want you to just take a minute, reflect on the past year, and think about kind of public health. And this is how I think we are looking at public health as public health practitioners. Despite all of the good work that public health does, it's mostly overlooked. If you remember earlier in the pandemic, there was the point at which we were coming out of the stay-at-home protocols, and people were regularly saying, "Well, look, you said there would be millions of people who died, and that didn't happen." And that's when I found this cartoon, and it really spoke to me, because this is the problem. Is when public health does our job, we're averting catastrophe, not mediating the outcomes of it. And so I think it's interesting that you have this perspective, but also this comes from now 6 years ago. I don't think it's really changed much, but it was a real poignant article that I read, a sea change in treating heart attacks. And this was about Camden, New Jersey, and how because of clinical care, we were able to improve outcomes of heart attacks. And it said no city seemed more in need of improved heart care than Camden. 42% of the population lives in poverty. Obesity is rampant, as are high cholesterol, high blood pressure, and smoking. The local hospital's cardiology department had long felt pretty cocky about how it was doing. Heart care is the hospital's specialty, and without its revenue, it would have to close its doors. So let's just take a second there. This is probably the greatest problem that we all are facing in the nation right now, is this disconnect between the cause of our health challenges and the cure. So the article, why I always find this article fascinating, is because it laid out the community level issues. It laid out the challenges of poverty and high cholesterol and smoking and all the things. And if you've ever been to Camden, there isn't a place to get, fresh, healthy food. There is a sense of despair in the community. There are high smoking rates. There are all of these things. And our solution was to really just focus on the healthcare aspect. So we're always trying to focus on the cure, but not the prevention. And I think when you think about the history of medicine, the history of health in the United States, there was this pre-medical period. And that's when it was about sanitation, it was about policy, it was about getting clean food, clean water, good employment, that was safe, right? That was kind of the early pre-medical period. Then I think we hit this medical period, right? And that's where we had vaccines and we had penicillin, and things became very medicalized. Our health was understood through a lens of healthcare. And we built a very expensive and expansive healthcare system all the way through the 1990s into the 2000s. But now, and this is our problem, is we're in a post-medical era. Now, that doesn't mean that medicine doesn't have a role, or that healthcare doesn't have a role. But what's killing us, what's causing our ill health, is nothing that can be really determined and treated inside a clinic. And so this is our challenge, because we spent a long time building this expansive and expensive healthcare network. And that's like a round peg. And it fit really well for a long time in a round hole. But now as our understanding of health has evolved to recognize that it is, what's available to us, in our communities for what we can eat. It's guns, it's poverty, it's predatory lending, it's all of those things that are beyond a clinician's realm. We just, we took that round peg and just jammed it really hard into what is now a square hole. And if you think about it, this is kind of where we are, right? We know, right, well, that social determinants of health is what's really challenging population health. But our response has been to buy more and bigger buckets to bail out the boat. We're not fixing the hole. And even worse, we have folks who are alleging to address social determinants of health, but they're really not, right? And that's one of the things I really want you to walk away from this conversation, kind of having a clear understanding that there are social needs and there are social determinants. And this is actually, Sue, interestingly, I worked for Sue 22 years ago at RWJ. And this was something that her and I have been talking about, and that is in the Future of Nursing 2030. It's this idea that there is this downstream clinical care. We all get that. And we've asked healthcare to move upstream, which it has done, but it's only moved up to kind of that midstream state. So anything and everything that is seen through a clinical individual lens is not social determinants, it's social needs. Okay, social determinants impact everyone, regardless of insurance or primary care provider. That's what we're trying to get to. We're trying to get to social determinants, because everything that you're seeing at a clinic, everything that you're seeing in a hospital are just really the downstream manifestations of challenges further upstream. Okay, and note here on the tactic side, when we're talking about really going upstream, it's laws, it's policies, it's regulations. Let me give you another way of thinking about this, right? So I'm trying to think of this as a kind of this health investment opportunity framework, because we're all making investments at different levels for our health. What we get is kind of this individual focus, right? So individual downstream, midstream, and upstream. Because you can have individual upstream, but it's still just through that individual lens, like the earned income tax credit, which helps individuals. It can help many individuals, but it's still helping individuals. Same thing with individual midstream, that's addressing those non-medical social needs. Here's some food for tonight. Here's a place to stay for a week. You've heard folks talk about the fact that you have diabetics who need their insulin stored in a refrigerator. And so they're providing folks who didn't have resources, apartments with a refrigerator, and that way they're saving on diabetic costs only until they choose not to give that apartment anymore. Right? That's not a long-term solution. These are short-term fixes, and they only help the individual. And then ultimately, your individual downstream is clinical care. Now, looking upstream, and we just tend to talk about upstream, but upstream also has different components. You can have kind of upstream, downstream, which are community food banks, which again, they're there, they serve a community, but they require a fair bit of individual agency to get there. Right? They're not long-lasting solutions. They are temporary. Then you get to like the community midstream. And this is things like Dignity Health in California, Kaiser Permanente. They're doing impact investing. Kaiser Permanente has invested $200 million in low-interest loans to get developers to build low-income housing in places where Kaiser has a footprint. Now, that doesn't mean that the housing only benefits Kaiser plan enrollees. It benefits anyone in their footprint, but then ultimately where we want to go is to this, far out box, this box 6, community upstream. These are the things that are impacting the community as a whole: rental inspection policy, complete streets, universal access to pre-K, clean indoor air. These are the things, and all of these boxes are nested because they accrue benefit with each other. So this is the perspective I hope that you will take away from this talk. This idea that really impacting health is all 6 boxes, but that the preponderance of our investment is in those gray boxes, if not this small box in the middle, right at the very end here. This 97% of our healthcare spending is in clinical medicine, 3% is in public health. We need to balance this better and make more investments kind of throughout these 6 boxes. And I pulled this from a talk I've given before, and I think it kind of focuses why it's important for nurses who are both clinical and non-clinical to be focused here. The quote, yes, I totally agree. Nurses need to be active participants in caring for patients, which means not turning a blind eye to the injustices that are occurring on a systems level. So when you think back to these white boxes, that's the systems level. These gray boxes are the individual level. Looking at that kind of framework, these are data from public health nurses working in health departments. And what we find is that health in all policies polls very poorly among public health nurses, that there's not an awareness of this kind of health in all policies perspective. And then I thought this was interesting. Again, we're talking today about health equity. I think Sue's going to talk about health equity as well. And this is, again, public health nurses in health departments. 90% say their health department should be working on health equity. 81% say they should be working on social support systems. But then you see, as we get to some of the components of health equity, the economy, housing quality, transportation quality, built environment, those start to fall down. And we do have things like nurse family partnership and other nurse home visiting programs that address some of these issues in the context of the individual patient, right? And that's still not the interventions that we need. I'll tell you a story from when I met with a community health worker who said she was working on the social determinants of health. And so I was very interested to hear what she had done. And she said, well, she was assigned Mr. Johnson. Mr. Johnson was a diabetic. He was non-compliant with his meds and often in the ER. So she was assigned Mr. Johnson. She figured out that Mr. Johnson's issue was really that he was lonely. And they spend time, they take walks together, they go bowling on Wednesday. And since her intervention with him, he's now totally compliant on his meds and he's not in the ER, probably saving the healthcare system tens of thousands, if not hundreds of thousands of dollars. And she said, there, see, I've addressed social determinants of health. And it was like, no, you have addressed the social needs of one particular human being, which is laudatory, but will not solve the problems that we have, because there are thousands upon thousands of Mr. Johnsons. And we don't have the resources to give each of them a person to go bowling with them. We could do a buddy program, which might be helpful, but a buddy program is only going to be there for as long as there is funding for it and interest in being a buddy. So the question is, what are we doing? How are we building our environments? How are we implementing the right transportation to ensure that Mr. Johnson has opportunities for social interaction outside of a person assigned by the healthcare system? So when I think of the future of nursing, of course, not being a nurse myself, I see policy development, I see informing it by data and using skills to create partnerships. So what I want you all to come away from this morning with is, first, that perspective, needs versus determinants, and making sure that you move forward forever using those terms correctly. David Kindig coined the term population health. And then he wrote an article several years after he coined the term that said, it's not what I originally said it was. It was redefined by healthcare, right? And now there's not really a good, solid, singular definition for population health. And so we don't want that to happen to social determinants. Social determinants are those things working at that community and policy level, while social needs are those things that are impacting a patient's health, but are outside the realm of the clinic. And that those two things are different. And they're equally important, and they need to be addressed that way. But right now, healthcare is focusing mostly on social determinants. Let me give you some social needs. So just some tips. You cannot bill for fixing the social determinants of health, right? CMS cannot have a social determinants of health billing code. The only way CMS could work on social determinants is if they allowed us to use Medicaid, Medicare money more broadly within the whole community, looking at the community more holistically. And some of that gets to these kinds of skills. So let's look at first policy development, which really helps us change the conditions in which people live. Now, we've all lived through a year and a half of COVID. And people always ask, why is COVID so much worse in the United States than it is elsewhere? And I would imagine, I suggest that COVID was the match, but we provided a whole lot of kindling for it with our decisions. There are policy decisions that we've made over the past at least 2 decades, if not past 400 years, that really impacted how COVID played out in the United States. And, you see racism and sexism and poverty are right central educational disparities. These are things that exacerbated COVID in this country. We knew before COVID happened that we were one of only 2 industrialized nations without a national standard for paid sick leave. We knew that most Americans didn't have savings. We knew this. We moved on. We kept gambling. And then we rolled snake eyes with COVID. Now, the big question for us from a policy standpoint, there were a whole bunch of vulnerabilities that were present at the start of COVID that exacerbated and facilitated the devastation of the virus. Are we going to address those vulnerabilities? And that has nothing to do with the vaccine. It has everything to do with policy decisions. It has everything to do with a livable wage. It has everything to do with policies that can control the acceleration of rents. Just because you're a property owner and a business moves in next to you, like, oh, I don't know, maybe Amazon, and you're maybe in, oh, I don't know, Seattle, all of a sudden your rents are jacked up 3-4 times. Now, we are allowing that to happen. And the people who are hurt the most are those people who no longer can afford those apartments. And they're pushed out further away. Now they have to get a car. Now they're getting up earlier in the morning. It's taking them longer to get to work back to home at night. Okay, there are ways that we are not creating an equitable space just from that kind of issue. But you could easily limit the increases in rent to a certain percentage of the existing rent or cost of living. These are policies that we can choose to implement that can protect people, that can close these vulnerabilities, but it's going to take policy. We talk a lot, especially from a healthcare standpoint, ACA, value-based contracting, all this kind of these healthcare machinations, how we're going to pay for healthcare. All of that is about managing disease, right? It's dealing with the flow of the water from the spigot. Policy can help us shut off that spigot. We are comfortable paying for something once it happens, but we are seemingly less comfortable to pay for the environmental and community level interventions that we need to ensure that people don't get sick in the first place. So when you look at this, here are just 4 examples of policy, right? And how they impact people's lives. So you take here in the upper left-hand corner, in the city of 1 million residents, 40% expansion of transit developments has resulted in an annual health benefit of $216 million. And next over, after rehabbing housing, 62% of adults have excellent health compared to 33% before. Early childhood education is associated with a benefit cost ratio of $5 for every $1 invested. Now I could go on a whole rant about early childhood because I see early childhood as essentially like having a cure for cancer that we just don't want to give everybody. Early childhood, when we talk about evidence-based intervention shown to work, shown to give you a return on investment, it is all there. And so while we're thinking about what we need in this country to be healthy, one of the things that is central to that is central to closing some of the racial disparities is access to high quality early childhood education. That would do more for us than probably anything else. And it's something that we just can't muster the political will to do. And then lastly, each time the earned income tax credit increases by 10%, infant mortality drops by 23 deaths per 100,000. Policy is the prescription for better health in this nation. In a post-medical era, you must have policies because that is what's preventing illness, is policy, not pills and procedures. So I want to share this. This is one of the resources that I want you to walk away with. And this is City Health, cityhealth.org. It's a partnership between Kaiser Permanente and de Beaumont. We have 9 policies. We've rated the 40 largest cities as to whether they have these policies, either a good policy or a bronze medal, a better policy, a silver medal, or the best policy, which is a gold medal. We are getting ready to redo this policy package. I encourage you to look at City Health. It gives you the steps as to what is a bronze versus silver versus gold policy. So I think it's about, we've been rating cities for about 3 or 4 years now. We've seen 59 policies enacted across these 9. We had less than 50% of cities that could even get a medal when we started. And a medal has a minimum of 4 bronze medals. Now more than half of the cities can. And we're expanding from 40 to 75 cities, and we'll continue to update our policy package to reflect the current environment. I hope to see new policies like livable wage or proactive rental inspection and housing trusts. But that earned sick leave is right there. And I'll tell you about San Antonio, Texas. San Antonio, Texas, just through policy, they were the first city in Texas to go tobacco 21. The entire state then followed suit in the next legislative session. They also have a gold medal for earned sick leave, which came before the pandemic. And that means that everyone had the requirement to provide sick leave, even with an employee base of one or more. So good work by cities to be pushing policy, to be creating those environments where people can live their best lives. Now, I'm reminded often that if you have fish, I don't know if anybody out there has fish. I like fish. They don't require a lot, and there's a lot you can do to make them healthy, and you can feed them the right food, and you can give them fish exercise, and there's a lot that you can do to make your fish healthy. But if you don't clean the tank and you don't change the water, your fish are going to die. Your fish are not going to be healthy, no matter what you do to them individually. And that's the perspective I want us to leave here today thinking about. From CDC, there is the health impact in 5 years, also called High Five. You can Google this, and it really identifies policies where social determinants and changing the context to make the health choice the easy choice. You'll see some of these policies are similar to those that we had in City Health. Some of them are at different levels, but you see early childhood education is there, tobacco control interventions. But these are all policies that are shown to have an impact on health in 5 years. Evidence-based policies, right? Just like you write a prescription, just like you get a prescription if you have high cholesterol, you get a prescription for Lipitor. If you have issues in your communities, these are the prescriptions to write. These are the policies. And lastly, there is this resource, Promoting Health and Cost Control in States. This is from Trust for America's Health, and it really outlines state level policies and identifies what states have what policies and how that can impact the environments in which we live. Let's talk about data. And I won't say a lot about data, but there is one thing that I can't not say because it's so important. We spent $27 billion. We, you and me and our friends, that was taxpayer money, $27 billion. It's part of the High-Tech Act during Obama's administration that helped us move to electronic medical records. And I think this was a good thing. I am perplexed as to why we can't find money to modernize the public health data infrastructure when we found $27 billion to do it for healthcare. I'm also perplexed as to why we can't find a way to aggregate these data and use them to inform our public health practice and the policies that we need to have. If you look at something like food insecurity is not something that distributes randomly throughout a community. We know that it clusters, and the data that are in the EMRs could help us figure that out. As people are now talking about trying to use codes to capture social determinants of health, and they're not, those codes can only get to social needs. But if you aggregate those data, you can actually start to see in the community in real time where certain needs are, and we can address those through policy. It is not necessarily healthcare's responsibility to address the social determinants of health. That's government's responsibility. But healthcare has all the data sitting in electronic medical records if we could just mine those data. Not necessarily at a patient level. We can come up with unique patient identifiers that allow us not to see patient names. But more importantly, if you have HIPAA concerns, if you work with a health department, HIPAA doesn't apply to health departments. So nurses who want to advocate for better use of data and better health, we can start right here by how do we liberate the EMR data so that we can use it better and more effectively to inform policy decisions that in turn will stem the flow of ill people into healthcare. Right. Next and lastly, I want to go into using skills to create partnerships. So this is kind of like public health Tinder profile. It's not very alluring, right? No one's swiping right on that profile. Forming partnerships is not just getting out there and saying, hey, we should partner together. And it's not the people that you necessarily it's not other health people. It's not public health people I'm talking about. I'm talking about education and business and other sectors, housing, transportation. And so we actually looked at partnerships And we asked folks from other sectors, what they thought about health and what they thought about partnership building. So let's look at health. How is health understood? Experts in public health say health is a positive state of integrated well-being. Leaders in other sectors say it's just an absence of illness. So how do you define health? I'm sure there are nurses who are at different levels of practice and have different practice sites. And what is your definition of health? How common is that definition amongst your friends and family? See, the challenge with health is we really don't have a good brain architecture for health. We have a great brain architecture for health care, right? We all kind of played doctor, played nurse, played these kind of roles as kids. Maybe some of you have children, you've seen Doc McStuffins. It was an ABC, it was a Disney show about a kid who played doctor. And everything really on that show was about repair. It was about returning people to health. But there was very little conversation about this first kind of idea of health, a positive state of integrated well-being. So this is a challenge. This is a challenge for us in achieving some of the things I talked about earlier, that perspective of, real community level policy change, because the absence of illness is just about you. Now, I'm going to suggest it's one of, I will usually pepper in a couple controversial statements. But even look at the Ad Council, and I like the Ad Council. I think what they're doing is well intentioned. But remember that whole their tagline of their ad campaign is, it's up to you. But is it? Is it up to you about getting a COVID vaccine? To a certain degree, it is. But then it becomes up to us to make places that have easy access, that make it easy for people to get to, that work for everyone of different, not all of us, nurses know this, not all of us work 9 to 5. I don't think my parents in my whole upbringing worked 9 to 5. There was a lot of 11A to 11P. There was a lot of 7P to 7A. So when would they have gotten, their shot? When they were sleeping, I imagine. Right. So this is the stuff we have to think about, right? It's if we can, the absence of illness makes this very individual and it moves away from a community focus. Now let's talk about how is cross-sector collaboration understood. Okay, because generally I think we believe that collaboration is a good thing. And public health experts say collaboration, it's valuable and needed, natural. Different sectors have overlapping functions and goals, so it's something we must do. Leaders in other sectors said it was inevitably strained and difficult, given that different sectors are fundamentally distinct from one another and occupy very different worlds. So our definition of health requires us to work across sectors. And so creating partnerships makes sense to us. But when health is just the absence of illness and other sectors coming into your sector is seen as infringement, pardon me, you get a different perspective of partnership. Now, we did extensive interviews. This is just a sampling of some of the challenges that we'll have making partnerships across sectors. But one of the resources I want to make sure that you leave with is phrases. Public health reaching across sectors. This is a toolkit for anyone who wants to make partnerships, anyone who wants to be that kind of chief health strategist idea. And what it does is it works you through metaphors, it works you through language, messaging. There's a whole tool on when you say they hear. And I hope that you will take the time to look at this toolkit and really think about how you can integrate this into your practice, even when you're talking to folks. And again, this is a very public health focused talk, but bedside nurses are talking to people and families every day. and at a minimum can make sure that we're working towards those social needs. Can learn how to talk to people from different sectors just in their own day-to-day interaction, when you're serving on different committees. When one of the sectors that we worked on with phrases was healthcare. How healthcare can understand public health and how it benefits your bottom line. And so all that is in this toolkit. And I hope that you all will really think about finding some time to review it and adapt these tools into your practice. So what I didn't say before is we also need to have really strong communication. For me, much of COVID-19 stands as a monument to really poor public health communication. So we spoke very certainly at the start of the pandemic, where there was very little science backing some of our comms. Wear a mask, don't wear a mask. Now we're 2, now we're 5, now take it off if you're vaccinated. This natural progression of changing guidance during a novel pandemic is natural to a degree, but it also fertilizes the misinformation kind of engine. And so we needed to couch things from start in, we don't know everything there is to know yet, but as we know more, we're going to share it. We framed this initial, the stay-at-home orders, they were framed as lockdowns. Where do you have a lockdown? You have lockdowns in prison. You have lockdowns. My kids have lockdowns when they have shooter drills at their school. Lockdown was not the right way to frame this. And then we didn't need to frame it as a dichotomy between dying from the virus or dying from the impacts of the lockdown, the economic losses. We never found a way to talk about Americans' shared anxiety. And this is our challenge. And in a politicized environment, the need for good communication is so much more important. So we need to communicate well. And again, wanted to share some resources to help you communicate well now and going forward. So one of the things I think is really helpful is the Public Health Communications Collaborative. The website is there. This was stood up by CDC Foundation, Beaumont, and Trust for America's Health. And it is providing messaging. It provides misinformation outbreak alerts, which is right here, misinformation. And it tells you what you should be doing with this misinformation, ignoring it, addressing it, and how to address it. We also have a commonly asked question and answer section and several infographics that people can use for free. Everything here is free. We have a monthly webinar where people who have communications challenges can ask questions of experts. For COVID, we also have this website, changingthecovidconversation.org. This is literally all the messaging that we've done at Beaumont, and we have a special interest in addressing vaccine concerns among Republican and conservative audiences. That's where we put a lot of our energy. That is a group that remains one of the most concerned. Notice I don't tend to use hesitancy, I use concern. That was something that we found in our polling. So there are messages here, there are focus groups. There's just a ton of good information about how you talk to people about COVID vaccination. And you'll note that from the Kaiser Family Foundation poll, nurses, doctors, healthcare professionals, they are a trusted source of information. And so I would like to see the day where COVID vaccination becomes a vital sign. Height, weight, do you smoke, are you vaccinated? And then you have 3 routes off of, are you vaccinated? Yes, they are. Good. No, I'm not, but I plan to. Make sure they know how to get that vaccine and they have a plan. And then, no, I'm not, and I don't plan to. And that's where we should have a brief clinical intervention to help people convert from not wanting to get vaccinated to wanting to get vaccinated. And nursing has a critical role to play in that. I also wanted to share this as just another resource. When we looked at nurses in the public health workforce, 64, now we had all together, this all comes from the public health workforce interest and needs survey. 47,000 respondents total. We pulled out the those who identified as public health nurses. 64.9% said that budget and financial management was a really important skill, but something they didn't know how to do. And so as I continue to leave you guys with resources, especially anyone who's watching this who is a public health nurse, look at beamskills.com. It's an asynchronous online certificate in administration and management. It is specifically for public health and program management in public health. And so I know, like for me, when I was in one of the states I was in, I had a brilliant nurse running my family planning program, our Title 10 program. She's a women's health nurse. I don't think there's a person on the planet who cared more about women's health, but she didn't know budget and finance. And so that limited the resources and how we deployed those resources to serve as many as we could, because that was missing in the skill set. Beam is there to help really address that in everyone, but nurses, as you see, that is a huge need among nurses. So something to think about. So what I hope I've been able to do is, I'd love to think that y'all are going to go home tonight and say, oh my God, there was this great guy. He was really handsome and smart and engaging. And it's Brian Castrucci. I'm going to start a little shrine to him in my corner. That's not going to happen. You're not going to remember my name, and that's totally cool. You're hopefully going to remember, one, the perspective, right? Social needs versus social determinants. And we've educated, more people today. 176 people now really get that distinction. And that's really important. And then there were resources. And I hope that you have these resources that you want to check out, whether it's PH Wins, which you can find at the Beaumont Foundation website, or it's City Health, it's FACTS. The FACTS is the short acronym for Public Health Cost Containment Council thing. Or it's High Five, or it's Beam, or it's Phrases, right? Because these talks, like I came up through public health. I started as an intern, and got all the way up to being an MCH and WIC director. And what I always wanted from these talks was something that gave me some knowledge and something that gave me some skills. And that's what I hope we've been able to do today. I leave this up. This is my email and my Twitter account, to Beaumont's Twitter. This is hopefully not just a first date. If there are issues you have, if there are problems you're encountering, and you need someone to help, think about giving us a tweet or an email, and we might see if we can help you with some of the resources that we have. We all have very similar problems, and we all try to innovate different and unique solutions when sometimes driving a nail just needs a hammer. And that's our business, is trying to really get the resources that people need. So I hope you learned something today, and I hope that you take some resources with you. And I think we have a good 20 minutes for questions. And so that's all I have. And thank you for your attention.
So thank you so much. I have a couple of things that I'd like to announce, and that is that all the participants will have access to this presentation for 30 days on the platform. And then there have been questions about, will the slides be available? Because people want to tap the resources. So the answer to that is yes. So with that, I've got two questions thus far.
Can I just interrupt for a quick second? The slides are public. So y'all can take, if you like a cartoon and you want to use it, use it. If you want to use anything in here, use it. It's all fair use. So you're not plagiarizing or copying. This is about information, and we're all on the same team. So let's use it together.
So the first request is, what are your thoughts around the health status of healthcare professionals? We're part of the public and often do not take good care of ourselves, and our organizations are just now starting to try to focus on our health as employees. You have thoughts to share?
Well, I think employee health, whether it's healthcare or public health. Now, as a public health professional, I am I really do believe that public health workers have almost had no employee health benefit at all. And I do think healthcare workers, I get annoyed when I go somewhere and it's like, here's a free ice cream if you're EMS, police, nurse, doctor, EMT. And I'll always ask, what about public health practitioner? And of course they say, I don't know what that is. And so no. But I do think we need to be very thoughtful. There's a lot we have to learn from COVID. How did we not have PPE? How did we not have strategies? Did we not know this was coming? I mean, let's be really clear. Any legislator, any elected official that has cut money for health or healthcare in the last, let's even give them 20 years, then the blood of 550,000 plus Americans is on their hands. The absolute kind of, burnout that we're seeing among healthcare workers is on their hands. We knew this was coming. If China parked an aircraft carrier off the coast of Georgia and our response was to cut defense, there would have been an immediate reaction from the public. But we have whittled away and whittled away and whittled away health and healthcare, and that's not acceptable. And so we need a reckoning. And this is where, the nursing associations, the public health associations, the physician associations, et cetera, really need to start talking to healthcare about how are we going to protect those who protect us, right? Because that's really what it comes down to, is you all and nurses. And again, as I said, both my parents are nurses. I have a bias towards nurses that, my mom used to say, physicians bill, nurses provide care. So that's not my quote, that's mom's quote. So if you don't like it, you blame mom. If you like it, you can say, I said it. So, but the point being, nurses were there to get our back throughout this entire pandemic, in the community, in the hospital, in the clinic, at the mass vac sites. And I don't think our society has done much at all to get your back. And that's something we have to reckon with. We have to reckon with that. We also have to reckon with the fact that most of these deaths were preventable. And the reason so many people died was not because of COVID. It was because of decisions that we had made 5, 10, 100 years ago that for the first time for everyone in America were front and center. It's like, I loved reading New York Times articles that were like, there are health disparities. Like, oh yes, though, just with COVID now, health disparities. We never knew about those before. That was never something we knew about. COVID has made it really hard to ignore things. And we were like super good at that in America. Like, that's our biggest export, ignoring real social injustice. And it's harder to ignore it now. And I hope we have a reckoning, but I'm too much of a pessimist to let myself think that it's going to happen. My biggest fear is that once everyone's vaccinated and we're all at the beach and we're all living our lives again, that we will just go back to the way things were. And COVID is like Mother Nature sending us a warning shot. The mortality rate was not inconsequential, but it was low. I don't know that I want to be around when this comes back at a 10 or 15% mortality rate. And we've ignored all the vulnerabilities now that have been punctuated for us. And you guys, the bedside folk know, it's like, what are we going to, it's like we had bypass surgery. And you're in recovery, and the first thing the patient asks for is a cigarette, and you're kind of like, well, we didn't really learn a lot here, did we? So are we going to be the bypass patient that smokes, or the bypass patient who eats well and exercises? I'm too concerned that America's already reaching for a pack of Reds.
So can you talk some about mental health and the importance of it within public health priorities?
I can. If you go to our website, we worked with Wellbeing Trust on, I think it's 60 policies that cities could enact that could help mediate the coming wave of mental health issues. And I think all too often when we talk about mental health, we boil it down to a clinical issue, not enough providers, not enough parity in care, but we also need the public aspect of that, right? We need to, again, create the conditions where people can be healthy mentally, and there is a report that outlines, again, 60 policies that cities should be enacting right now that will help them and their residents deal with what's going to be a significant mental health issue going forward. I mean, we also, mental health is coming, evictions are coming, right? We didn't do rent forgiveness, we did rent forbearance. So the bill's going to come due unless we do something. And that's going to be really challenging for a lot of Americans who might find themselves out of a job. And what I think is most perplexing about this pandemic, so I run a private foundation. First, as the market dropped, we started moving assets around. We started thinking about how we're going to survive this, because we survive on 5% of our assets. So when our assets drop, what we have to spend drops. But then a funny thing happened on the way to today. The market started going up and going up and going up and going up, which is it doesn't even make sense. It is in total opposition to what you all and most public health people are seeing every day. More mental health issues, more homelessness, more hunger. And so this is where I worry about where we're going, because those in power really weren't hurt by COVID. Those in power are afraid of Ebola. It's egalitarian, right? Everyone can get Ebola. COVID, by attacking and by being, by the burden of the disease being amongst Black and brown and vulnerable communities, meant those in power didn't feel the bite. And they're not really going to act when they don't feel that bite. That's what worries me. And the mental health issue is right there.
So any comment on the impact of obesity on the COVID-19 pandemic, and what opportunities do you see for public health to act on it as the United States struggles with the obesity epidemic?
So, this is part of our challenge, right? I'm surprised you're asking me about obesity, because I thought we solved that, right? We had moved on to the opioid crisis. So I imagine when we were dealing with the opioid epidemic and we stopped talking about the obesity epidemic, it's because it was solved. But I guess you're suggesting maybe it wasn't solved, so that we have multiple epidemics running and we don't have the attention span to stick with certain things, right? And so we need much more comprehensive approaches to health problems. We deal with obesity while the money is with obesity. Let's even go further back. We dealt with tobacco. And that was really important until all the money went to AIDS. And then we all became AIDS researchers. Until all the money went to obesity. And then we all became obesity researchers. Until all the money went to opioids, then we became opioid researchers. And we've never fixed, probably with the acceptance of tobacco, which is probably one of our greatest successes. We've not fixed these other problems. And so we have to be thoughtful about obesity. We need comprehensive strategies. We need to fund public health, not, and yes, Alzheimer's and diabetes and obesity and heart disease and high blood pressure. All of these are important. But what it really gets down to, education and poverty. Jonathan Fielding, who is a genius, and he was the Massachusetts Department of Health commissioner, and he was in LA County for forever. If you ever want to get one of his books, it's well worth the read. He said once, if I really wanted to impact health, I would take all of the money that's in the health department and just give it to the education department. Because if we can get people out of poverty and get people educated, health tends to track with that. There's a whole infrastructure in our culture, in our country, that needs to get money for their disease. And what it does is it makes it near impossible for us to actually address things holistically. Why am I having, diabetes, hypertension, heart disease, high cholesterol? Do we all not agree that they pretty much, when you push further upstream, they're all flowing from the same original source? but we're set up in a structure that doesn't let us address that holistically. And so we end up chasing our tail on the, disease du jour. Jonathan Fielding, and he's in LA County. He wrote several books on health departments. And I think my favorite is the chapter where he talks about, remember, this is LA County. Jonathan is a physician. He's tall, Caucasian gentleman. Now he's older. And one of the places he was giving a public health lecture was at the Adult Video News Awards. So you never quite know where public health and healthcare are going to take you. And it's an interesting chapter in his book. So he's brilliant.
So this isn't a question, but just a shout out, because COVID has accented school health nurses and the role that they need to play in terms of the care of children. Just wanted to acknowledge that. So can you speak to who are the best entities for healthcare systems to partner with to really address the social determinants of health? Which problems should this partnership address first? For example, bang for the buck. Is it housing, early childhood initiatives, education, which I think you just told us, transportation? What is your opinion based on the data?
So most of those things are flowing from government, right? And I've often said that I think healthcare got conned. Okay, I think you all got swindled. I think government came to healthcare and said, hey, this housing crisis, it's really hurting your patient outcomes. You should really work on housing. And healthcare went, yes, we will need to work on housing. You are right. Thank you. What healthcare should have said is, that's not our issue. That's your issue, government. Your issue is housing. Your issue is food insecurity. It impacts us because we're seeing the downstream manifestations of those problems. So what I think healthcare needs to do is it needs to do two things. One, start speaking up. You are typically in most places the largest employer. Okay, so you have to get out there and you have to say, listen, here are the data. Here are where our problems are. Here's all three of us. Because if you're in a community with 3 hospitals, chances are the top 3 things in your community health needs assessment are all the same. They may be in different order. So you all shouldn't be addressing those apart. You should be coming together, right? So that's the first thing. Get out there, talk to your city council, your county commissions, tell them what the problems are, show them the data, and put the responsibility on them. And then it's not a clinical play. It's a money play. Okay, so we talk about food insecurity, where a hospital can identify where there's food insecurity, could put low interest loans on the street to get grocery stores to come in, work with the city council to drop taxes on that grocery store so that it can get there. Because what I've learned from working in WIC is that grocery store margins are razor thin. So there are places they won't go if they feel that those razor thin margins can't be maintained. By lowering taxes, by lowering the interest rates on the loans, you make those margins a little easier. Let's talk about a whole bunch of listen, we sent like a robot. We sent a robot to Mars, right? Didn't we just do this? Am I right? Like a robot. And it like got out and it collected stuff and it sent stuff back to Mars. It's another planet. Like we did that. That to me is like what Harry Potter does. I don't even understand that. We can do that. But if I got like 30 kids who all keep hitting the ER, different ERs because they're having asthma problems, persistent asthma, and they're in different insurers, I can't find those 30 kids. I don't have a data system where I can find those 30 kids. More importantly, I can't figure out that those 30 kids all live at the same apartment building. And the problem in that apartment building is the HVAC needs to be replaced, but the property owner can't do it. So you can treat these kids all day long. And it's just going to repeat the cycle over and over until somebody, and this is where hospital administration needs to evolve. Hospital administration looks at these data and go, do we notice that like all our asthmatic kids are coming from, or like a large proportion of these asthmatic kids are coming from this apartment building? Maybe we should go to talk to the property owner and say, listen, we'll give you a low income loan. You're going to change out the HVAC. Even if he defaults on the loan or she defaults on the loan, you'll make it up in savings. You know you will, right? Because those kids now aren't going to come to hit the ER. You're not going to have kids inpatient admits for, asthma, which is like, shouldn't happen. But it's because if our focus stays on the fish and not the tank, we don't go forward. And that's the thing we have to learn. I tell hospitals all the time, it's not a clinical play, right? Because clinical engagement is an individual art by definition. We need to now look at how and who treats the water. And that's a mix of government and healthcare and business. Because you have to, and for healthcare, it's right there because your patients don't have, the patient outcomes that you want are unachievable because the water in the fish tank is bad, but it's not necessarily your job to treat that water.
So we have a lot of positive comments in the chat in terms of the presentation, and people are really grateful. We've got 3 minutes before we have to take a break.
No, just to be clear, we have 3 minutes before this session ends. And since I live on Twitter and I live in my email, we're going to keep, if you don't get a question answered here, throw it at me on Twitter and we'll have a conversation there. This does not have to end by the time bounds of this session. Just want to throw that out there.
Thank you. So as a nurse leader, how do policies related to sick time positively affect me and my team? Sick time causes staffing problems due to abuse of the system. And what considerations taking when writing policies to ensure they don't solve one issue and create 10 more?
So my wife and I were having this fight this morning around telework policies. And so I'm going to push back. And if your immediate step is sick leave policies create people who abuse those policies, then we are not looking at the right place. That's a performance issue. And you need to deal with that as a performance issue. But this was the fight we were having. The fight we were having was telework. And she had something from her boss that was like, you can't do this, you can't do that, and abuse. And it was all preventing the abuse instead of rewarding those who did it well and used it appropriately. And I get it, because she said to me, Brian, you're thinking about you're literally running scenarios of abuse and writing your policies against those scenarios. You've never run the scenario of they've teleworked and productivity's up. People have been teleworking and they're fine. And so what if someone chooses to work out at 10 a.m. instead of 7? If they're still getting their work done, it's not impacting their performance, why do it? So there are always going to be bad apples. And I think I would force us to say they don't have to spoil the barrel. And that you deal with them up front. And if someone is chronically out, then you deal with that and you work with HR, right, around those issues. But, paid, every other industrialized nation in the world, except us in South Korea, have figured this out. And so again, when we're up dancing around on Mars, I got to think that it's easier to figure out how to get this nation paid sick leave than it is to figure out how to put a robot on Mars, right? And so it's just that pushback. And again, I might have had a different perspective if my wife hadn't yelled at me this morning and been so adamant about you were only thinking about the negative. So I get it. Like I get the issue, but the first thing we say, if you're sick, stay home. A lot of people can't do that. I'm not staying home. If it's my house, if it's my rent, if it's my kids, if it's feeding my kids, screw you. I'm coming to work sick. And then the CDC has this awesome guidance that if you are sick and at home, isolate yourself into one room, assuming I have more than one room. Assuming that, I remember a health commissioner at a large meeting we were at just as COVID, it was the same day that Nancy Messonnier said, this is all going to go really badly. And we were all like, did you hear what the CDC said today? And someone said, in our city, we have 2-bedroom apartments with 5 people. And we have no way to track that. And so how's that going to work in quarantine? If someone is quarantined, because of COVID, but isn't on the lease, you can't make them quarantine at that place of residence. They actually don't have a place of residence, even though they're paying rent under the table. So many complexities in this that we just didn't think through. And America has a choice to make. Do we go back to sleep or do we stay woke? And I worry that people are already grabbing for the sleeping pills, and we'll just go back to sleep once it all goes back to normal.
So as the son of two nurses, we thank you profoundly for this thought-provoking talk. And I do hope that America stays woke. And I think you've challenged us to potentially think in different ways. So thank you for being with us today.
Thank you. We'll talk on Twitter.
We'll take a 15-minute break and then reconvene.